Hey guys, welcome back to another video. My name is Shamira if you are new to my channel. In this video, I have another what it's like in real life as a medical coder. We're going to be reviewing an operative note and looking in our ICD-10 book and CPT book. So if this interests you, then keep on watching. For those of you that are completely new to medical coding, what this is an operative note. So this documentation is from a doctor that had a patient in the operative room, performed a procedure, and he had to put documentation in the patient's chart in order for us to bill for it. Our role as the coder is to review the documentation, assign the appropriate codes that will go out on the claim to the payer or the patient to receive reimbursement. At the top of the note is the reason for why the patient is having the procedure done. So the patient was admitted to the hospital with a brief history of left pelvic pain. An ultrasound revealed findings of left ovarian cyst. The patient now presents for left oophorectomy after discussing therapeutic alternatives. We have the pre-op diagnosis, post-op diagnosis, and the pathology report gave us a more defined diagnosis of what they received. The surgeon would have put the ovary in some type of specimen container that would have got sent off to pathology, and then pathology will determine if there were any malignancies, benign tissue cells, all that. So that is what they found when it says here ovarian serous cystadenoma. Now let's get into the findings. Well, before we get into the findings, let me just point out that the pre-op diagnosis and the post-op diagnosis, we would not need to report because we have this diagnosis from pathology. So whenever you actually get a diagnosis from pathology, you no longer need to report the pre-op or post-op diagnosis code because this N83292 would have just been like a other cyst code. We know it's ovarian serous cystadenoma. That is what we're going to code. Now let's get into the findings. We have normal vulva and vagina, surgically absent uterus and right ovary, vaginal cuff intact, left ovarian cyst on the left ovary, mild adhesions to the bowel bilaterally. The left fallopian tube was not clearly identified. On the right was a 5 millimeter adhesion from the bowel to the right infundibulopelvic ligament area. The liver edge and gallbladder edge are normal in appearance. So we can report a code, actually two separate codes, one for the absence of the uterus and the cervix. Even though it doesn't say that the cervix is missing, I know because there is a vaginal cuff that is intact. Whenever they take the uterus and the cervix, the patient is left with the vagina only. So when they close off the vagina, that is the vaginal cuff. So even though the documentation doesn't say they took or that the absence of a uterus and the right ovary, I know the cervix is gone because they closed off the vaginal cuff. And then we can also get a code for the right ovary being missing. I laughed because I said missing, but you know what I mean, surgically absent. All right, now we can get into the actual operative report. So it says the patient was taken to the operative room where she was correctly identified and the procedure verified. She was prepped and draped in the usual sterile fashion in dorsal lithotomy position. A sponge stick was placed in the vagina at the vaginal cuff. The bladder was drained with a Foley catheter. After changing gloves, the infraumbilical area was infused with 0.25% Marcaine. A 5 millimeter vertical skin incision was made in the infraumbilical fold. A Veress needle was inserted into the abdomen and pneumoperitoneum was obtained with 3.5 liters of CO2 gas. The 5 millimeter choker and sleeve were advanced into the abdomen and intra-abdominal placement was confirmed with the laparoscope. A 5 millimeter straight scope was used for the procedure. Additional 5 millimeter port was placed in the left lower quadrant under direct visualization through a previous scar. A third port, 10 millimeter, was placed in the midline lower abdomen under direct visualization. All port sites were infused with Marcaine before the incisions were made. What I want you to get familiar with and what I want to stand out to you is where it says there was 3.5 liters of CO2 gas. They are putting air gas into the abdomen. So that way, as they perform this laparoscopic procedure, the patient's abdomen is going to be inflated. So it's giving them more room to see. If this were an open procedure, meaning they are cutting the patient open, they would not be having any type of CO2 gas released into the patient. I also want you to be aware and pay attention to the size of the incision that was made. It says a 5 millimeter vertical incision. Do you guys know how small that is? There's no way this is going to be an open surgery. This is a laparoscopic procedure. When you see the words trokers and ports being placed, imagine in your head, I don't know how many videos I've seen of Dr. R.K. Mishra on YouTube, watching him perform laparoscopic procedures. That helped me a ton. So I would suggest you guys also watch laparoscopic procedures, actually see the surgeries being done, because it makes so much sense when you are reading these operative reports. Okay, so all this information here that we went over in this section of our op report is only us prepping before we actually get to the meat and the potatoes. So on the back of this paper is actually going to be our surgery. So I will go ahead and flip this over. I'm doing a voiceover, so sometimes I'm a little bit faster than the video. So here we are on the back. It says the left ovary was elevated with a grasper using the 5 millimeter cool seal. The adhesions to the left pelvic side wall were dissected, and the ovary and cysts were dissected off of the pelvic side wall. So there were some adhesions, probably from a previous surgery. Adhesions are scar tissue. The ovary was regrasped and the infundibulopelvic ligament was cauterized and incised. The reason why I'm pointing at this infundibulopelvic ligament is because all OBGYN coders should know when this ligament is cut, that means they're going to be removing the ovary for sure. This ligament is what keeps the ovary attached to the pelvic side wall. So they cut it. In the process, the cyst was noted to be ruptured, releasing a small amount of clear fluid. The left ovary was fully excised. Excised means removed. A laparoscopic bag was placed through the lower port. The ovary was able to be placed into the laparoscopic bag. It was brought to the skin surface within the bag. The ovary was then able to be fully removed within the bag. The lower port was replaced and an adhesion on the right pelvic side wall to the bowel was cauterized and cut using the cool seal. The pelvis was copiously irrigated and drained. Good hemostasis was identified. No further adhesions to the pelvic side walls were visualized. I'm going to pause right here because I know what's going on, but you guys probably heads are spinning. So up where it says the left ovary was fully excised, a laparoscopic bag was placed through the lower port. So they can put little plastic bags inside these ports. I know you guys would have seen a video previously of that scope going in or the trocar going in. They can put little bags inside these ports, and then they can use their other trokers or instruments through the trokers to put things inside the bag, and then they pull the ovary up through the tube. So that is what happens, and that's how they got it out. The ovary was placed inside the bag and then came up through their trocar port. Then we have further survey of the abdomen revealed findings as noted above. The lower ports were removed under visualization and no bleeding was identified. The scope was removed. The gas was released. The umbilical port was removed. The fascia of the lower midline port site was closed with a suture of 0 vicro. The skin incisions were also reapproximated with subcutaneous sutures of 4.0 vicro. Steri strips and bandages were placed over the incisions. The sponge stick was removed from the patient's vagina. The patient tolerated the procedure well, and she was taken to the recovery room awake and in stable condition. You guys, we are through the operative report. The patient is alive and well and done. We are done. So now we need to figure out what CPT code we are going to be billing. And again, for those of you not familiar with these type of terms, where it says the gas was released, they now are removing the air that they put into the abdomen. Let's see, fascia of the lower midline. If you know, like the layers of the skin, they have to close the fascia, then like the subcutaneous layer, then the skin. So that is where they put the steri strips on. They close her up. The procedure is done. Before we get into the CPT book, I'm just going to show you guys everything I would have highlighted that stood out to me in this op report. So enjoy the music and watch me highlight. Okay, so for my OBGYN coders, you guys should have already known that left oophorectomy, that is going to mean the left ovary has been removed. So medical terminology is something that is important when taking your exam. Now I'm just going to pull out my CPT book, and we are going to be in the back in the index section, and we're going to look up oophorectomy. So let me just look for that. Let me move my book over actually a little bit because the lighting was better to the left. So once I find oophorectomy, I'm just going to reposition the camera. Here we are. So oophorectomy. And then we will go down to laparoscopic because we know this was done laparoscopically. And these are our 4 codes to choose from. So when you're taking your exam, you would just want to have like scrap paper, write down these codes, but you would probably have multiple choice options anyway. But these are going to be the 4 options that we can choose from. So what you want to do is you will write down these codes and then you will go to that chapter and read the description of those codes to know which one you would use. So let me grab my paper here, and I'm just going to write down those 4 codes. Once I have these codes written down, I'm just going to flip my book over. And do not judge me for still having 2023. My employer only gave us the option for either CPT or coding companion. So I went with coding companion for 2024. But I do not have a 2024 CPT book. I'm pretty sure the codes are the same. All right, so once we get to our first code, which was the 58548, you will look for that, and you see here it says laparoscopy surgical with radical hysterectomy with bilateral. Absolutely not. We can cross that off. There was no type of hysterectomy done. Our next code was the 58554, which is the laparoscopic surgical. Another hysterectomy code. That is not correct. And then we have the 58552, another hysterectomy code. So we are only left with the 58661, which is underneath the laparoscopy section. You will read this as laparoscopy surgical with removal of adnexal structures, partial or total oophorectomy, and or salpingectomy. So the and or is what gives it away. So whether they did it or they didn't take both the ovary and the fallopian tube, you are still using this code. And you may want to add the LT modifier if you are taking the exam. I usually don't report it for my real life coding because most payers will not ask for it. Now we will look up our IC10-CM code. So in my IC10 book, you will go to cisadenoma, and you will normally look for something like ovary or serous. So here on this side, and fun fact, I actually did a short for this, so you guys already know how to look this up if you've watched my YouTube short from today. But for the sake of the video, I'm just going to show it again and be more thorough in this one. So we have a cisadenoma up here at the top, and then we are going to go down and look for serous. You see I have borderline malignancy, papillary, and then I have 4 other things highlighted. I accidentally highlighted these 2 by accident, but what I really wanted to highlight was the specified site down here and unspecified site. So we know the specified site is the ovary. So we would have to go to the neoplasm table. My neoplasm section is in the middle of my alphabetic index. Some people, after the alphabetic index, you may have the neoplasm table. You just have to find it wherever it is in your ICD-10 book. So underneath neoplasm, you will look for ovary. And then you're going to go in the column of benign, because remember it told us, it said neoplasm benign by site. So you want to go look in the benign column, and it tells us D27 point dash. So you have to look in the tabular list, which is the chapter section, for the D's in order to know what you are going to replace that dash with. So let's jump over to D27. And here we are. It says D27 benign neoplasm of the ovary. It says use additional code to identify any functional activity. So excludes twos. You can code these codes in addition to the D27 codes. And excludes one note, which you see down here below. You could not report D28 codes with any of these excludes ones codes. So always think excludes one, you can only use one. Excludes two, you can use two or more. So for us, also these indicators here, if you look at the bottom of the page, it'll tell you what they mean. So we had a triangle, so this code has been revised. And then there was also this blue indicator, and then the number 4 for the digit indicator. So the blue arrows means laterality. You should know the laterality. And then the number 4 tells us that there is 4 digits of this code. So if you had a multiple choice answer that only said D27, you can eliminate that because that will be an invalid code. Our code we're going to use is D27.1 for benign neoplasm of the left ovary. So that is it, you guys. I'm just going to flip my page over and write down those ICD-10 and CPT codes. Now, you could code those adhesions and the surgically absent uterus and the ovary. That would be the Z90. I wrote 720 and Z9722, but I had to double check in my book, and it was actually Z9710 and Z9721. And I will show you guys that at the end of the video. So these two codes here is for the absent uterus plus the cervix and the right ovary. And then I also went and looked up the adhesions and what I would bill for the adhesions to the pelvic side wall. So I went in my alphabetic index to adhesions, and then you would look for bowel, and then it tells you to go to peritoneum. So once you got to peritoneum, it did say pelvic, and I think it said like female pelvic or something like that, which sent me to N73.6. But then I also seen the subsection for N99.4. So that is what I went. Here is what I was talking about in the alphabetic index. You see adhesions, bowel, it says peritoneum. Then we went to peritoneum. We dropped down to pelvic female. And then I went to the subsection for post-procedural, where I got the N99.4. I thought I recorded the other codes, the absence of the uterus and the ovary, but I don't have that footage. So I'm sorry, you guys. But if you have your ICD-10 books, go ahead and look it up for yourself. I will see you all in the next video. Thank you for watching. Bye, guys.